Good evening. Thank you all for coming out tonight. As Deb said, I practice across the street in conjunction with Dana-Farber and Brigham Women's. And today we're going to talk a little bit about brachytherapy. So that's basically the seeds which can go into the prostate to cure prostate cancer. I'm going to do a little bit of an overview, and I'm going to repeat a little bit of what Dr. Bamberger spoke of, but maybe just put things in a little bit of a different spin or a different light, because there's different ways to present some of this data. And we'll look at some of the incidence, mortality, prostate function, touch again on the PSA controversy, because you are seeing a lot of that in the newspaper nowadays. We'll look to see if treatment actually is needed for low-risk disease. And of course, I want to compare brachytherapy to surgery, external beam radiation, kind of let you know what I do in conjunction with Dr. Mickley and Dr. Bamberger, and some brachytherapy philosophies. And importantly, what are we doing here at Milford? Again, the incidence, it's high. Over 200,000 people will be diagnosed, or men will be diagnosed this year alone with prostate cancer. 32,000 men will die of it. It's the leading cause of cancer in men. So there's nobody here who's not going to be affected by it in some way, shape, or form, family member, friend. It's common. It's the fifth most common death. So it is not something to be taken lightly, but thankfully we can diagnose prostate cancer earlier and earlier, and as such we have a lot of great treatment options. There's estimations that 1 in 6 men will get prostate cancer. And the incidence increases with age. But 1 in 125 guys from 50 to 56. But look at this, when you're 70 to 79, 1 in 2. It's pretty common. Risk of death will vary with biology. Gleason scores, as we were talking about. More aggressive the disease, the higher likelihood it needs treatment, and the higher likelihood it could be problematic without treatment. But there's probably a 9-year reduction in life expectancy. There's probably 2 million men walking on this earth with prostate cancer, either not known in treatment or just waiting to see what happens. What does the prostate do? Well, Dr. Bamberger basically said we don't know, and it's true. But it's a walnut-sized organ between the bladder and the rectum. We know it helps with procreation. We know it helps secrete a fluid which will keep sperm or the ejaculate in a liquid form, makes it easier for us to father children. A lot of the ejaculate is actually fluid from the prostate. And this is where the PSA comes from. It's a protein secreted by the prostate, specific to the prostate, and this is what we're looking for in elevation to help us diagnose prostate cancer. Again, PSA screening controversies. We heard about this, but what are the pros and what are the cons? The pros in the PSA era, starting in the late 80s, or late 80s I should say, we've detected a lot more organ-confined disease, meaning we can find prostate cancers before they become problematic. That means we have better treatment options, we have many treatment options, and you can really actually tailor this to a patient, and it really becomes a patient's choice. It's less suffering from advanced disease, it's simple and relatively inexpensive in itself, and it's objective. It's a number we can look at. But the cons, it's not absolute. There's no PSA where you don't have prostate cancer. There's no elevated PSA where you do have prostate cancer. There's potential for unnecessary biopsy and worry. The global healthcare costs associated with prostate cancer are probably close to $3 billion, and that's why you're seeing this in the newspaper, and that's why we're saying maybe we shouldn't screen. Well, maybe we can find other ways to kind of ratchet down cost. Not all prostate cancers need to be treated. We overtreat, we know that. And there's conflicting reports on effectiveness. There are huge randomized trials looking at this, and I'm just going to present a little bit of data, but in the US, we looked at screening in 76,000 men. Does it help? Our study said no. We did detect a few more cancers, but it wasn't significant. It didn't increase mortality. But there's a problem with this study. 52% of the patients in the control group who didn't get treatment or screening or PSAs actually did, so it probably diluted the effect. The Europeans are the same trial, looking at a lot of men, 182,000. It's mind-boggling numbers, and they did detect a lot more prostate cancer, and it led to a significant 20% reduction in mortality, 20% risk of not dying. Again, we looked at a little bit of this, but the AUA recommends screening, and if you have high-risk disease, you can start as early as 40. The American Cancer Society says, well, we don't really recommend it unless you have to have a discussion with your doctor. You need to know what you're getting into when you do get this test. If the number comes back elevated and you have no intention of getting treatment, well, why do it? So it's a little, a little bit of discussion is necessary, and I think that's an important thing to do, and I know our docs do that very well. And when you're probably reading the Milford paper, the New York Times, the Boston Globe, last week the U.S. Preventive Service Task Force came out and said, we don't recommend prostate screening. Don't get PSAs. It's too expensive. We don't know if it really works. Well, we do know that we have to screen probably 1,000 people to save one life. Same thing with mammograms or breast cancer for women. They made the same recommendation against mammograms 2 years ago, but it really didn't take flight in this country. If we can save lives, we try to. So the benefits of screening, we're finding disease clinically confined 90% of the time in this era. Pathologically, meaning it didn't go through the capsule, someone had a good question, 80% of the time. Before, 50% of patients could be metastatic, meaning the prostate cancer is outside of the prostate, in the lymph nodes. That's down to 2 or 3%. That's pretty good for screening. And in my opinion, we do need to screen. We have to find the higher risk disease. We have to find the people who warrant treatment, but we don't always have to treat very low risk disease or low risk disease. And these are conversations you have to have with doctors. And if anyone ever looks you in the eye and says, you absolutely have to have this because if you don't, you're in trouble, I'd get another opinion. So how do we define low, intermediate, high risk cancer? Well, Dr. Bamberger touched on this. This is a more appropriate slide before the strike, but basically clinical exam, PSA, and Gleason score. We know what clinical exam is, we know what PSA is, and Gleason score is just what the pathologist sees under the microscope. He looks at everything, assigns a number between 1 and 5, 5 meaning bad news, 1 meaning not too bad. Then he looks again and sees what he sees the second most of and does the same thing. So your number can be between 2 and 10. Risk stratification, Dr. D'Amico is in my group at Brigham Faber. He kind of became pretty famous doing this risk stratification. But low risk disease, Gleason score less than 6. Intermediate risk disease, Gleason score 7. High risk disease, 8, 9, and 10. And of course, we put into the clinical examination and PSA. PSA less than 10, low risk when you're diagnosed. 10 through 20, intermediate. High risk greater than 20. We pigeonhole things. It's a spectrum of disease, but this helps us with our clinical trials and figuring out how to talk to patients. Does low risk cancer need to be treated? Do we save lives? Well, a big Swedish study, which was looking at radical prostatectomy versus doing nothing. Wait to see what happens. If your back starts to hurt, then we'll try to find out what happened to you. Did find the benefit. Decreased mortality, decreased death from 11 to 6.8%. Decreased metastatic disease by a whole lot more. But the caveat is only 5% of these patients were screen detected, meaning that only 5% had PSAs, therefore we're probably finding a slightly higher population of patients. Another study published this year, the PIVOT trial, made a lot of news, big splash in the New York Times. This study says that radical prostatectomy for a low-risk patient population, and again, there's a lot of caveat, and that's why you need to talk with your physician, wasn't finding a benefit. Decreased death by about 2.5%. For higher risk patients, though, there's a 7% reduction. How do we interpret this? Both of these trials, and we won't get into all the nuance, were probably more intermediate risk patients. So in reality, we don't know the best option for low risk patients, and we know some patients don't need to be treated, but we do have options, and we do need to have these discussions. But just to kind of put your mind at ease, I know a lot of you in this room have prostate cancer. We have time to make our decisions. Well, how's brachytherapy? That's what I do. I'm a radiation oncologist. I specialize basically in GU, prostate testicular radiation. That's what I do. How does it compare with other treatment modalities? Brachytherapy is something I believe in, I love, I was trained to do it. And so let's see what we do. Quick slide, because I keep saying brachytherapy, but what is it? It's elegant, it's simple, it's effective, it's quick. You're basically putting needles, without cutting into the body, you're putting needles through the perineum, that little spot right there, into the prostate. You're depositing seeds, you're taking the needle out, you leave these radiation seeds behind to go ahead and affect change and affect death of these cancer cells. We'll talk about this a little more in a bit. What are our long-term outcomes? This is kind of a who's who of prostate brachytherapy. Blasco and Grimm, the fathers of brachytherapy, my mentors in Seattle, Merrick, my research partner in Virginia. We know 5-year survival is a biochemical control. Everything's based on PSA, because even if your PSA goes up, you're not going to die. We can buy you several more years typically. But meaning your PSA doesn't budge, goes down, you're doing great. 95% of 5 years, 85% of 10 years, 80% of 15 years. And those are all the techniques, honestly. Walsh, famous urologist, Johns Hopkins University, recently published his data. He's like, well, what are my 5-year, 10-year, 15-year outcomes? Numbers are the same, 95, 85, 80. So very similar. It really becomes a personal choice. There's no one right answer for anybody, but it's nice to know you have options. It's always good to have options in life. The SPIRIT trial. We tried to do a head-to-head comparison of brachytherapy and surgery, but imagine that. Imagine you walking into a physician's office and I said, I'm going to flip a coin, and if it's heads, you're going to get surgery. If it's tails, we're going to give you brachytherapy. Tough sell. I don't think it's a difficult thing. We did randomize 34 people to that. They agreed to the flip of the coin. We got some others in the other groups. And this was just published. Now, 5 years, brachytherapy is looking good. Not big differences, but there are differences in urinary domain, doing pretty well, sexual function, probably a little more potent, and patient satisfaction. Again, it's a personal choice. I do want to point your attention to Peter Grimm. This is a guy who I trained with in Seattle, and he's taken it upon himself to try to help compare and help us figure out what the best treatment options. We don't have a lot of randomized trials, so we've got to figure out with all the literature out there, what's the best thing to do. He's looked at over 18,000 papers with a kind of another who's who of prostate brachytherapy and prostate cancer down there. 848 articles are identified, and the goal is to help physicians, patients, insurance carriers to figure out what's comparatively effective. Insurance companies don't like to pay for things that don't work, so we want to try to show them what is working and what we're doing. This is low-risk disease, and this is kind of slick. He basically has each geometric design is a different treatment modality. So in this situation, whoops, no, that's not it. Let me see here. So the blue circle is brachytherapy, red triangle surgery, and the little green squares are external beam radiation. And then that number is basically the reference. You can go back and look what was published. And brachytherapy or external beam radiation surgery all look great for low-risk disease. So all very, very good treatment options. Well, what about intermediate risk disease, the Gleason score 7s of you out there, the PSAs between 10 and 20, failing something on exam, same thing. There's a lot of good stuff, and this is what's in the literature, though. This is what we go by, evidence-based medicine, and we know brachytherapy does very well. Typically in the intermediate risk population, I do combine it with external beam radiation, but we know it's effective. These are the numbers. High risk. High risk, we don't typically do prostatectomies for because the cat, if you will, has already left the bag, although there is some change in this country right now. But again, this is what's been published to date, and the brachytherapy combo of radiation, external beam, and sometimes we throw hormones into the mix, looks pretty good. So what are we doing here? How are we advancing prostate brachytherapy at this institution? Well, brachytherapy is the precise placement of low energy seeds, these isotopes. We use computer-generated planning. The physics behind this are pretty daunting, but with the right supercomputers as we have, you can figure out the right combination of seeds in the prostate to affect cure. We're putting the seeds right in the prostate, right next to the cancer, so we're affecting things locally. So we're not treating from the outside in as I do with radiation, from external radiation. We're treating from the outside in. I've got $10 million of machinery across the street to do what I can do with $1,000 worth of seeds. It's minimally invasive, highly conformal, and highly effective. Seeds are small, tiny. You usually get 50 to 70 of these placed into the prostate. They stay with you for life. They're made of titanium. They don't set off metal detectors. You do pretty well with them. Again, picture, same picture. Seeds being placed by needle and prostate, needle removed, you go home. Which patient should get brachytherapy? Well, historically, it's been for low-risk patients, so the Gleason score 2 through 6, PSA less than 10. Although the ABS, the American Brachytherapy Society, which are very active, I'm one of the chairman of the membership committee, so obviously I might be a little biased. However, we're basically we're starting to relax our regulations to implant some of the intermediate risk population as well, because you see from the past slides it works well for intermediate and high-risk disease. So for full disclosure, neither the NCCN, which is this big cancer regulatory system in the United States, or the ABS recommends brachytherapy as monotherapy, but it is allowed as a boost. So you can augment some dose, give a little dose of radiation to kind of make up for anything you might miss with seeds, although I would argue high quality implants, you don't need this. In fact, I presented 2 trials nationally this year implanting intermediate and high risk patients without external beam radiation or very little external beam radiation. And the criticism, well, your implants are just too good from the groups that I've worked with. The rest of the country can't do it. Well, be as it may, we probably should work on being better as a country, and I'll show you the techniques we've done here. So I do implant favorable risk patients, the Gleason score 7s out there. Then we look at the amount of cores positive and some of the other things, a lot of nuance, but this is the discussion you have with the radiation oncologist and urologist to figure out if you qualify. There's a big national trial that's looking whether or not this is a safe thing to do for all comers. Lots and lots of institutions, lots and lots of different experience levels. It's still an open question nationally. We have to involve 566 to this trial. I think we need 40 to go. So we'll have these results, but of course it's going to take 10 years to really figure out what it all means. So, that's where we're stuck at right now. The French have been doing this for quite a while, monotherapy implants, and they've got great results. These are 5-year data. Obviously, you'd like to see 10, 15-year data, but looking pretty encouraging that seems to work in this patient population. Question always becomes, is brachytherapy good for young patients? Historically, prostatectomy, if you're less than 60, less than 70, you're probably going to get a prostatectomy. But again, it's nice to know there are other options. And we have a study from Potter, who's a very good brachytherapist in New York, looking at his less than 60 and greater than 60 population, low, intermediate, and high-risk patients doing pretty much equally as well. Merrick, one of my research partners, has looked at patients less than 54, 8 years, low and high-risk patients are doing very well, 96 to 100% control rates. And he took it one step further. He's very comparative, looking at less than 50. And those patients are doing well as well, also less follow-up though. In erectile dysfunction, that patient population, well, 75% of men are keeping their erections if you pay attention to the neurovascular bundle. And Dr. Mickley, I'm sure, is going to go into this. But there are places where you need not to give a lot of dose or not take out with surgery if you want to not affect erection troubles. And how does this compare to prostatectomies in patients less than 50? Very similar. Prostatectomies work well too. So to know where we're going, I always say it's important to know where we've been. And prostate brachytherapy has actually been around since the 20s. We used to put iridium needles in the prostate, put them in temporarily, and take them out. 1960s, gold seeds, difficult isotope to work with, really never got that much traction. 1970s, Memorial Sloan Kettering, we're opening a patient up. Instead of doing the prostatectomy, they were just actually putting the seeds in that way. I love this picture because this is the physician's finger in the rectum. When you were pushing the needle in, if you felt a pinch, you went too far. Obviously, very difficult to control, difficult to reproduce. The control rates were horrible. The bond era of brachytherapy is 1980s. This is the transperineal approach, basically going right through that little piece of skin because the prostate sits right behind it. Somebody in Hansholm in Denmark had this great idea. We have ultrasound imaging, which allows us to see things now. Why don't we do it this way? He taught this to Ragay and Blasko, John Blasko, and Peter Grimm, the grandfathers of brachytherapy in Seattle, and they went off and running with this. The first implant was performed in Seattle, Washington in 1984. They used to do pre-planning. I'm just mentioning this because when you talk to other brachytherapists and when folks watch these videos, how do we do things differently than others? Pre-planning is still very good in competent hands, but it is kind of becoming a little different, as Dr. Bamberger was alluding to, how we have different technologies and different ways of doing this nowadays. In the old days, you would do 2 studies. You do a volume study, measure the prostate, figure out what you want to do, put this information to a computer, come up with a plan. 1 or 2 weeks later, go to the operating room and try to execute that plan exactly as you wanted. The advantage was you had all the time in the world to plan. You weren't under the OR clock. You knew exactly how many seeds to order, and you're in and out of the OR, usually within 35, 40 minutes. The disadvantages is the prostate can change shape over time, and you got to set things up perfectly when you get back in. And that isn't as easy as said than done. This is the old Seattle technique, but most of the seeds on the periphery, some seeds in the middle. Everything has to be uniform, robust. Prostate, no matter what it looks like, always looks the same. Nice and robust. That's the way it used to be, nice and symmetric. We don't have to do this any longer, but this brought us to where we are today. You stand on the shoulders of the giants before you. In 2001, ABS, an organization that's near and dear to my heart, issued a challenge statement. It basically said, you can do better. Ideally, one should strive for real-time intraoperative dosimetry. You should know exactly what you did before you left the operating room, and that's what we're doing here at Milford. You need to be able to see your seed placement, and you need to adjust on the fly if you have to. You need to be confident you're achieving exactly what you set out to achieve. This is a whole soup of what's going on. And so when someone tells you, if you see another brachytherapist someplace else, we do intraoperative planning, you probably kind of want to ask, well, define that. Because intraoperative planning could simply mean that they do a pre-plan in the OR, kind of do the old-fashioned technique. As long as you don't move the probe from the rectum between doing the planning and doing the implantation, that's intraoperative planning. I would caution that there are there are different ways of doing this. And we're striving for interactive planning, where you want to interact with your needles. You want to be able to update the position real time. If I put a needle into the prostate with Dr. Bamberger's help or Dr. Mickley's help, we want to make sure it's spot on, and we have ways to do that. We want to make sure that before we leave that we're happy with everything we did, or change things to make sure it's perfect before we go out of the operating room. Again, what are we doing here? It's sad to see this slide, but we get MRI scans of most all our patients. Someone asked, well, how do you know if it went past the capsule? Or what if I had negative biopsies? Typically, you can't really see this. I know this is kind of a waste, but the central zone is up here. So there are places where we don't biopsy all the time where cancer could be hiding. It's nice to know that because I can give you extra radiation there if need be. We can see tumors and we can basically dose escalate or give more dose in those areas. This is something that just wasn't feasible 2 or 3 years ago. Again, we do intraoperative interactive planning. In the OR, when we do the volume study, we do 500,000 calculations of the proper needle and isotope positions. 500,000 with supercomputers. It takes less than 2 minutes to do. We look at it, make sure it's perfect. We might tweak it because humans are always better than computers. But everything's three-dimensionally based, computer optimized. And this is high speed. This is some of the best in the country. We've married the best technologies, the planning systems from Germany, ultrasounds from Japan, seeds from the United States, and we basically built something from the ground up, and we're doing what we need to do. You generate DVHs. I could tell you exactly how much you're giving your prostate, but more importantly, how much your urethra and your rectum are getting. This is important stuff because you only want to treat what you need to treat. And you can interact with the plan. You can update all the needle positions. Again, simply just putting seeds in we make this sound real complicated, but just putting seeds in the prostate. We use a quick loader. It's an infinite arrangement. Anything that we need to build, we can. Whatever the computer system tells us we need to have a great implant, we can build, and we can link them all together. By linking the seeds together, you can do an extracapsular implant. You can implant seminal vesicles. All that means is when we're presenting data and saying, well, we do pretty well, we probably don't need beam. Well, our implants are different. Bigger treatment margins, implanting the proximal seminal vesicles when need be. We can do things slightly differently because of the technologies we've married. Seeds within the prostate gland, that's what it looks like. Simple, 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 all linked together. Real-time planning, 100% of the dose has to cover the entire prostate, but then we actually get kind of fancy. We know this green is where the cancer's most likely would be. We can put 150% of the dose there, and we also know where the cancer may be by MRI or prostate. We have a map, and we dose escalate to 200% of the dose. We can get away with that safely because we know what we implant is basically what it looks like, and I'll show you how we know that. We have DVHs and targets. We play Battleship in the OR. This is actually the one time that Dr. Bamberger and Dr. Mickley and I have a good time. We get to color coordinates. It's all calibrated to the true implanting systems and the ultrasound. This corresponds, these needle tracks correspond to this grid, and that's how we know we're getting into the right place. And we use live sagittal views. All this means is, here's the cartoon. It's like, hey, dummy, that's where you need to get that needle. Here comes the needle. It's a virtual needle track is presented. We insert that isotope to the indicated depth. We have a physicist, a PhD physicist in there with us saying, yep, that's good, that's not good, tweak this, tweak that, we're gonna update this. That way at the end of the case, we know exactly what we did. And we interact with our needles, so we know where they went. We can do real-time implant evaluation before we leave the OR. This is important. Before you go, we do another volume study. We overlay our isodoses to make sure we achieved what we wanted to achieve. None of this waiting 30 days later to make sure we did what we set out to do. Prostate implant evaluation is important. This is a slide I taught the Harvard Brachytherapy course 2 weekends ago, and this is a slide with 15 highly experienced brachytherapists across the country, and you can see there's some dichotomy here. There's some difference in opinion of where everything is. You need to be honest with yourself. You can make anything look good if you're just circling stuff, but for me to tell you we set out to do what we set out to do, you have to have an honest implant and ways of doing that. The way we choose to do that, the gold standard is getting an MRI scan at day 30. You can't really cheat on MRI. MRI delineates your target. CT scan's a little more difficult. It's not projecting very well, but there's a difference. And because of that, you know you hit your dose parameters. So when it's all said and done, you need to evaluate. We know what we need to achieve, and we better make sure we met those. And we present our data nationally. We QA our data with everything in town. We go back and forth between here and Boston. So we make sure that we're on the up and up. And when we set out to do something, we do. And we're doing high quality implants. You can only do a good implant if you can accurately contour. You need high quality ultrasound. You have to design a curative plan. You need these supercomputers to help you do it. You have to execute the plan. You need systems in place that you can put these seeds and these needles where they need to go. And then you need to actually sit back and say, yep, that's what I set out to do. And here I can prove it to everybody. That's what I wanted to do. So I always tell people I'm teaching, become proficient in what you do. You have to honestly evaluate your technique, and you always have to strive to improve your outcomes. Last couple of slides, and I'm going a little long, but what is radiation exposure from brachytherapy? I get this question every day of my life. This is a great study. This is hilarious, actually. Someone took radiation badges and meters and put them on everything: the patient, his wife, his dog, his walls, his house, his kids, you name it. And essentially, the exposure to the spouse, his wife, who would theoretically have the most contact, was less than the radiation exposure than you would get from a flight from Boston to San Francisco. If you choose to come back to the guy, then you're going to get double. And secondary risk from brachytherapy, you know, every radiation oncologist will tell you, especially we all had to train in pediatrics and we've all had to give real young kids radiation, and we do know that there can be some secondary malignancies associated with radiation in the young setting as you're still growing. When you become an adult, that's less so. We're worried about colorectal and bladder cancers because that's where the prostate is. It lives right smack dab in between the rectum and the prostate and the bladder. And some were found, but mostly because of increased screening. That's why I make sure my guys get colonoscopies within 3 years prior to the procedure, because just because you have one cancer doesn't mean you're off the hook for anything else. So there was a great study looking at the SEERS database, which is just this national database. If you get a cancer, you get thrown into this. And looking at over 235,000 patients, we do know when you look at prostate cancer or any kind of cancers in the pelvis, so you know, kind of in the vicinity of where these radiation seeds would be, or external beam radiation would be, you have a 0.16% excess risk. Pretty small, a tenth of a percent increased risk with external beam radiation. There is no excess risk with brachytherapy. But these are questions which come up, and we've looked at hundreds of thousands of patients to answer that question for people. So in summary, I'm biased. All options are very good, but prostate treatment brachytherapy is something that we put on the table for folks. Minimally invasive, convenient, outpatient procedure, usually out of the hospital within 5 hours of the implant. It's a viable alternative to surgery. Surgery is always a great option. Excellent reported outcomes, as I showed you. Acceptable side effect, excellent quality of life, and it's cost effective. We don't talk about costs, but this is one of the less expensive ways to treat. Thank you. Any questions?
Are you curing or postponing with this method?
Well, curing if you state that you're looking for biochemical control, and we know that if we're going to ablate the cancer, we're giving ablative doses of radiation. So we're trying to give the functional equivalent of a prostatectomy, meaning taking it out, but we're doing that with radiation. So not only do we affect and kill all the cancer in the prostate, we kill the function of the prostate as well. So we're not trying to prolong, we're trying to cure you. And that's what some of those graphs were showing you before.
If you have an enlarged prostate, are you a candidate for this type of procedure?
Well, yeah, it depends in the sense that we used to say 60 cc's, which is a pretty big prostate, would be the limits. A lot of it becomes whether or not your pubic arch, your bones are interfering with the needle tracks. With some of the techniques we have, you can implant bigger prostates, but you really have to now pay attention to a patient's urinary symptoms. You have to get flow studies. You have to make sure they're the proper candidate. Have I implanted 80 cc glands in my life? Of course. Should you always? No. You really have to kind of cherry pick the patient population and make sure you're not going to do that person any harm. Because again, surgery is a great, great alternative, or external radiation.
Now, do those seeds stay in for the rest of your life?
Forever and ever and ever. They're made of titanium, they're inert. Your body doesn't know they're there. You don't react against them.
If you go through the airport, do they
Never seen it happen. Never seen it happen. You do get a card just in case, but I've done lots and lots and lots of these, and I've never had a patient say they set up a metal detector. I'm waiting for the first one, though.
Just quickly, about how long are you in the OR with one of these?
And the intraoperative procedure we're doing now, from going in, beginning on the anesthesia to going out, is about a little less than 2 hours. The insertion portion is about 30, 40 minutes.
Does brachytherapy or the external beam radiation preclude any subsequent surgery?
Well, salvage prostatectomy. So now the question becomes, well, what if this doesn't work and you locally recur in the prostate only? You can do salvage prostatectomies, but they are kind of fraught with complication. It's difficult to operate in a field which has been radiated. So that's, that's always been the argument. Well, if we do a prostatectomy and if the cancer comes back, you can always get radiation. True. But a lot of times it's not coming back within the prostate. That's why these cure rates for these low-risk disease aren't 100%. A lot of guys may be presenting with some micrometastatic disease, meaning it was outside the capsule. We just don't have ways to detect it in 2011, but it's someplace else. If we can prove that it's locally recurrent, and we're starting to get better with doing that, carbon-11 PET scans, all these kind of sophisticated functional imaging tests which are available to us nowadays. If I could prove to you that it's only in the prostate, we can consider salvage prostatectomy, but there's increased urinary incontinency rates. Cryotherapy that Dr. Bamberger was talking about is a good alternative. Hormonal therapy. This year alone, we've invented, they've released, FDA approved, 3 new drugs to treat prostate cancer, kind of a chemotherapeutic approach or immunosuppressing approach, and 2 more in the pipeline, which will be approved next year. So the goal is to eradicate the disease locally, so hopefully it never will become an issue in the future. But I wouldn't, unless we could really prove to you it's exactly right there, surgery is not always the greatest option.
Any other questions? Just get to.
Is it true that this method was discovered because it's so difficult to do anything else to the prostate?
Yeah, well, back in the 1920s, radiation's been around for over 100 years, and we've had ways to implant different things into different tumors. Before we've had sophisticated ways to control bleeding during operations, this is what we were left with. Was it the best thing? It was the best we had at that time in the 1920s, but it's a whole different animal. But yeah, some of the stuff did arise because that's what you had, and you do what you have to do. But this is completely different, and what I'm doing now here with the technologies we have, are really different than I was trained in Seattle. We were obviously looking and exploring, and we're doing some of the interactive planning, we're writing some of the original papers to show that this could be done, but it really wasn't packaged into these treatment planning systems where anyone could purchase and become proficient with. It's a game-changing thing over the past couple of years.
Well, thank you.
Okay,
That was
thank you.
wonderful.